as I invite up our speakers, Senator and Becky and Julie and Robin, come on up, I want to give you a little more sort of background on how we, through the convening panel, approached this lunchtime panel. And first we said, well, you know, there's this election going on. Come on up, grab a chair. And so as a convening panel, we decided that what we would do in the Senate race and in the governor's race is to invite the incumbent first. And if the incumbent wanted to participate, then we would also invite the challenger. And that the incumbent in the Senate race being a Democrat and the incumbent in the governor's race being a Republican, that was as fair as we could be without being sort of overly political, and really tried to stick to that. Senator Begich said yes, of course, and then we had to wait for the Republican primary to be completed, and so we extended an invitation to Dan Sullivan. He took a little while to make a decision, and then when he declined, after that point, we had a solicitation, some outreach from the new Walker ticket, and so while we had previously invited Governor Parnell, he had previously declined, we invited him again. Because the situation had changed a little bit, and the response was, we would really like to be there. We don't know that we can make it, however. And so we kind of hung out, and we waited. And ultimately, he couldn't be here today, but we had this empty panel to fill. And so we wanted to fill it with people who, if Governor Parnell said, that I wanted to join you, that we could fire them all, and they'd be okay with it. And so we did that. And Julie and Robin and Commissioner Struer and Regional Director Susan Johnson all said yes. But of course, turnabout's fair play. And Commissioner Struer had something come up, and Susan Johnson had something come up. We were able to pull Commissioner Struer from our program. We were not able to pull Susan Johnson from our program. And so as of even this morning, I had Robin from MODA, I had Julie from Alaska Regional, and I had 2 empty chairs. So thank you to Robin and Julie for being flexible. And Senator Coghill and Becky Holtberg from Ashna, thank you guys for joining us on short notice. You had no opportunity to prepare talking points, but I'm sure you'll all be great. And the purpose of this panel was really to sort of extend the conversation that we had over dinner last night, and that we've been having in the hallways today, and try to talk about what the future of Alaskan healthcare really looks like, or maybe put differently and subtly but important, what the future of healthcare for Alaskans looks like. And so, you know, Robin, I'll start with you with a premise from last night, which was, I think Tony Miles, I believe, from Sol Reeves said this, which is we shouldn't be thinking about what perfect looks like, and we should be thinking about what the next 7 iterations look like on our pathway towards getting better. So if you could maybe jump to the punchline, jump to the end, and look at this iteration of reform, the question we asked last night, if we look back on now, 5, 6 years from now, and say, we did that one thing during that time period, what would that one thing be that you think would be a definition for success in reforming and changing Alaskan healthcare?
I'll also respond, I think, with one of the responses from last night. Do you want to throw in world peace also at the same time? Well, I think I would say it's a little bit more than just one thing. First of all, it's convening discussions like this, like the meetings that Ashna has or other groups around the state to actually bring people together to have these conversations about what can be done and what does this look like. So first of all, that's because everybody's got to be at the table and have a part in these conversations. And that's what's happening. So if I jump now to the punchline, what is the one thing that could be done? I think the prospect of a demonstration project somewhere that would involve a lot of the components that's being talked about, quality outcomes, payment reform, patient engagement, provider engagement, some type of demonstration project that could be done is ultimately what 5 years from now we would look back and say, it's that one thing that we did. We had a lot of lessons learned there. It's not an easy path. It's not a straight path. There will be a lot of learning experiences, but that was the one thing that we did 5 years ago that got us to this point.
Mm-hmm. And when you say demonstration project, you're talking about Medicaid.
You know, I think what I would say is there needs to be a prominent sentinel event. If you could do that in the public sector, that would be fine, but right now the private sector, or the public sector is driving this, not the private sector. So you've got to start, I think, somewhere in the public sector, and obviously Medicaid would be the place to start, because I don't care what state you're in, expenses are going up and revenues are falling or flat, and you need to do something. And I think it's possible to do an Alaska solution, but I think it needs to start as a demonstration.
Yeah. Julie, same kind of question, but I'll add, of course, the background that as CEO of Alaska Regional Hospital, you've not been in Alaska 20 years. You're relatively new to the scene. Given your broader multi-state perspective, what would you think the one thing Alaskan healthcare can do in this period? What should that be that defines success?
You know, with my my history as a case manager lends itself to some practical use too in my role, and especially being the new girl in town and coming from what I see as the future. The piece that I think is missing is really looking into the lower 48 and say what worked and what didn't. Mm-hmm. Because there's a lot of solutions that are out there, but it's a matter of do we have the courage to take one and give it a shot. And I think what Robin is describing is spot on, and we have to try one and see how that works. Yeah. Because there's plenty of answers. But whenever somebody's asked to change, and quite frankly, everybody's going to have to change. We're going to have to do more with less. Patients are going to have a little more steps involved in getting to care, and providers are going to have to accept a different form of what the world looks like to them as well, but nobody's really willing to stomach that yet. And when we talk about change, all of a sudden there's the death panel threat coming up, and people are seen as something that it really isn't. So I would hope that we can help people open their eyes and see that this is the time to do it. Because when they forced managed care on us 25 years ago in the lower 48, we didn't want it. We figured there's nothing wrong, just let us play it the way it is. But I think everybody's right now, and I think they'd be willing to listen.
Yeah. So is this period of reform and care coordination and working collaboratively, is that all managed care of 20 years ago under a different name? Basically,
but it has to, you know, back then it was a heavier hand, and it was being, you're telling me what to do, what I can't do, and it was all threats and overtures as opposed to something that could actually help somebody.
Yeah.
And where I think the benefit is, because there's things in the lower 48 that are not wonderful, we know that, but how can we twist that so that it's patient-focused and patient-centered, and they see how it improves their outcomes, not just, you know, a matter of making it harder for me to get what I need. Yeah. Because people basically care about the expense involved up until the point it doesn't cost them anymore. Yeah. So where is that?
So, Becky, one of the questions I have, and I posed last night at this dinner, is I just am not entirely convinced that healthcare can right itself, and that if it would have been able to fix itself, it might have fixed itself already, but that the market is what it is, and the way that the market works in healthcare is just a little different. And so if it can't fix itself, that would suggest some sort of market or hand of government to become more engaged. What do you think? Can healthcare fix itself, or do we really need a little more engagement from the Department of Administration, which you used to head, the Department of Health and Social Services, or government generally at all levels?
I think the question that we need to talk about that we don't always talk about is, what are you paying for? And the way the current system is designed right now, we are paying for what we get. And from a payer standpoint, I was very cognizant as my thinking evolved on this issue that, you know, I was pointing fingers at cost, and I was pointing fingers at outcomes I didn't like, but that's what I was paying for. And so I think the central, can healthcare right itself? I think healthcare can right itself, but it will only right itself when we look at what we're paying for. Are we paying for the outcomes that we want? Are we paying for, you know, are we getting good value from the healthcare dollar we spend? And so I think from a payer standpoint, whether you're, and when you look at the government is its primary, you know, it has a regulatory function, but it has huge responsibility as a payer. Mm-hmm. And so whether it's a government payer or a private sector payer, payers need to begin, I think, to take some to look at what they're paying for and to think, if I don't like the outcomes, what do I need to do different? I am the one writing the check.
So, Senator, you're the one writing the check, too. $2.7 billion, I think,
2.7, yes.
that Alaska spends on healthcare. I'll pose to you the same question. Can healthcare in Alaska fix itself, or does it need a little bit of prodding from the legislature or budget writers or the administration to right its ship?
I probably will resist the word fix because it's a journey that we all are on. Like Becky said, the people who pay are looking for outcomes. But the payer and the consumer sometimes aren't the same people, right? Yeah. So we've got to get them closer. So in the safety net system like Medicaid, the accountability and the responsibility of the consumer is going to be more and more demanded by the Medicaid payer, the state. On a private system, it's a whole different ballgame. The private system says, we have a need, and we're willing to pay this much for it. Come get us your best bid.
Right.
But even there, you have the third party, whether it's an ERISA plan or whether it's an insurance that says, we're only going to do medical home models. And if you want to be with us, that's what you're going to do. That's fine, but it's different than, say, the safety net issue. Yeah. And then we have to, as legislators, we have to think about the broader public health issue. That's immunization, obesity, vitamin D, as we said earlier in a panel, the prevention model. So we have to think of them not as a monolithic system. They are systems of health. Mm-hmm. And whether it's public pay, whether it's public health, whether it's private pay, and pity the poor person who has cash because he has nobody standing with him to bargain, right? Or her. And so at this point, the people who are the payers are the ones pushing the system, if you will, if you want to call it the payer system, that starts demanding what that health outcome is. Maybe totally different what the consumer expects. And so the consumer and the payer have to be closer and closer together. And I think we're in a good time in history that says, you know what, the bill's coming anyway, so we better figure it out. Some of it is risky behavior. Some of it is heavy-duty users that we just can't afford anymore. So accountability has to come to them. Right now, there is no accountability. So you're going to see that more and more. And then the end-of-life care. I mean, I'm kind of the baby boomers that are coming at a breakneck speed into the end-of-life issues, and we're going to have to pay attention to that. So as a policymaker, we have big questions on how do we deal with the end-of-life issues without falling into kind of those politically hotly charged issues like, are you going to kill people? Are you going to just withdraw your funds and let them die? What's the value of life? What's the value of the dollar? So those are big decisions that end up at the legislature. And by the way, we have to do meetings like this and hobnob with all of you because we have 90 days. And it's like a giant squeeze that tries to get every big issue settled in 90 days. So this is very important. So I appreciate you inviting us and letting me hobnob with y'all.
Yeah, that's great to have you. Julie, you know, being a legislator or being the governor is, particularly a legislator, I think is an impossible task to fully get your hands around healthcare and actually come up with some real solutions. I mean, as a citizen legislator, you got other things to do, and but even a governor who does not come from healthcare per se, you know, it's very difficult. So if you, and they have a host of issues on a 90-day legislative session, what would your advice be to Governor Parnell or any governor in Alaska when it comes to healthcare? If they could focus on one thing, what would you say this is the thing to focus on?
I think that there are some statutory opportunities that could be reviewed, and I can't recite them specifically, but I do know that there's certain rules that are in place that could take another look to see if that might reduce some of the barriers for a free market strategy, and also, you know, how you make decisions on what managed care should look like and so forth. So,
are there values or maybe a vision statement that you'd say, you know, keep your eye on this rather than in the weeds? You know, Governor, really focus on this kind of horizon issue rather than the minutia of statutes.
Well, with that, it's pretty simple. It really comes down to what would you want for your mother? And there's a lot of moving parts within there, but what would you do for your most cherished family member? And what would you be willing to move to help make sure that happens, knowing that there's a lot of pieces in the middle?
Yeah. You know, Robin, you have done a lot of work around Alaska connecting MOTA with providers. One of the topics that payers have talked about, particularly in the commercial space, is speaking of rules, is the notion that providers are paid at the 80th percentile of community UCR, and some have advocated that you actually cannot put downward pressure on providers when there's a floor, or essentially a floor. What do you think about that, and do you think that the legislature or the agency, the department, should make a change to that administrative statute or administrative code?
Well, I think if we focus on the rate of payment that is occurring today under a fee-for-service model, that is more of the same in what we're going to do. Whether you reduce that to 75 or 70 or adjust it, that is just continuing the rate of payment that we're doing today. And I think we all would agree that that's unsustainable. Yeah. Back to my 5-year from now question, it's unsustainable. Yeah. And so payment reform has to be part of that. Yeah. And you've got to look at how can you really structure payment reform? It is possible to do, but you have to bring everybody together. You have to have hospital specialists and primary care all agreeing to participate in this. You have to provide some assurance that you're not going to push people off the cliff. Because how do you incent, for example, lower ED utilization and the loss of revenue there just by simply cutting how we're going to pay providers? How do you ask providers to take on more and more responsibility of coordinating care if we just go back to the same model and cut that? Yeah. There has to be shared savings. If there's savings that are created by the system, there has to be an opportunity to allow providers to repurpose people, repurpose services. There has to be a way to get money back so that when they produce savings. I'll give you an example. One of the hospitals that I've worked with under the Medicaid program in the state of Oregon called one day. He said, you know, proactively, I put a navigator in my emergency room to redirect people to less expensive service when they came into the emergency room. He said, well, I've got a problem. I'm paying the salary of the navigator, and my ED revenue just dropped by $250,000. Why would I continue to do this? And that's the point. If we just continue to do the same things, there is no incentive to do it. That's where the shared savings model under the Medicaid program that we run comes into play. He gets now a share of that savings, that he can pay that salary of that navigator. He's not penalized for reducing ED usage, and he can repurpose some of those people for other purposes.
Yeah. So, you know, Becky, in Oregon, in this model, there was a law and there was a governor who was a third-term ER doc as governor, and one of the most probably important governors in the last 100 years. Can we get there in Alaska, and can we get there without a third-term ER doc as governor?
I don't think I can answer your latter question. I don't know of any third-term ER docs who are going to run for governor. But I think
there's
we have
a family practice doc over here.
Yeah. Who is now shrinking in his chair.
Yeah.
I think we have to start thinking about these questions. I mean, what Robin said is really spot on. If all we're talking about, and that's my concern, is all we're talking about really is how do we take a chunk out of this provider or this provider group or this provider group so we can lower costs. That is completely ineffective. It is completely ineffective over the long run in managing cost. And so it is really really needs to be about these complex conversations about how do you get better outcomes for lower cost and enable your providers to share in the savings, your payers to share in the savings. And we're not having those conversations. And I think that's what needs to begin to happen here is how can we look at a pilot project, whether it's a pilot project with Medicaid. Peace Health in Ketchikan just did a CMS innovation grant. They have lowered their CMS payments between 15 and 22% overall. So you have to ask, why would a hospital hire care coordinators to reduce readmissions to lower their reimbursement? Tell me how that makes sense under our current model. But is it the right thing to do? Absolutely, it's the right thing to do. But we have to, but the financial model has to align with the right thing to do.
Yeah.
And so we need to have those kinds of conversations.
So there's I think the reasonable and the sustainability, there's a reasonable argument that focuses around financial sustainability and that this is an iterative process, and let's not blow the system up tonight in order to make it, quote, better tomorrow. But then there's this other argument, and it sort of, I think, gets encapsulated in the question. I'll pose it first to you, Senator, is there enough money in healthcare today? You know, is there enough money to do everything that we want to do in healthcare? Can we be successful without increasing from 24% of the Alaska economy to 25% of the Alaska economy? What do you think? Is there enough money in healthcare? Heck of a question.
I don't feel qualified to answer that question. I would tell you this, there's not going to be more money.
Yeah.
So that means we have to get creative. So whether there's enough or not, I don't know if I'm qualified to answer that because I honestly don't know.
Well,
but I can tell you we don't have enough.
Yeah, let me ask everyone that question real quick. Julie, what do you think? Is there enough money in healthcare?
I think that we could do more with less and at least stay where we're at.
Yeah, Becky, is there enough money?
You know, I think sometimes, again, I'm not a healthcare economist. I don't know that I can answer that question. But, you know, we're having a hospital, conversation here tends to be on the acute care side. We haven't even talked about long-term care, which is where the budget is really growing.
Right.
And so we have to be addressing all of our cost drivers.
Yeah.
And I think it's going to be a challenge. I agree. I understand the budget projections. I understand, what Senator Coghill was talking about. But as we look at the aging of our population, the way our long-term care system is structured today,
Yeah.
we're going to have some budget pressure ahead on that side.
Robin, what do you think? Is there enough money in healthcare?
Under the current model, no. Under some type of different model, there is. If you just look at triple aim, are we really doing the triple aim to the best of our ability today? On all fronts, clinical, payment, population health management, my response would be no. We can do better, and that's where there is enough money, I think,
Yeah.
within that.
So, Senator, what are gosh, this is complex. You just heard one person said yes,
Well, no,
there's
I
enough.
agree with Robin. My caveat was we'd have to do it different.
Yeah, in a different model, right. Getting your hands around the complexity of this, on the one hand, as I said, you're a citizen legislator. On the other hand, you authorize checks of $2.7 billion. And some would argue that because of the way the commercial market is so divvied up, exchange, small group, large group, individual, et cetera, that no payer can do what the state of Alaska can do in terms of forcing the market in a direction. The Department of Administration was looking in that direction. As a legislator, what are the kind of values that you bring to a budget that would inform the Department of Administration or the Department of Health and Social Services to sort of guide them in a direction?
I wish I had the answer.
Yeah.
But I'll tell
That's
you
the right
a
answer, by the
couple of
way.
things that we're going to be looking at. First of all, like I said, on the payment model, you have to get the consumer somehow tied to the cost of the value. And if that means the third-party payer, the safety net people, you have to get them together because that's the accountability. Probably one of the breakthroughs, we're in a good time in history, I can tell you, for hospital care, but the long-term care is going to be an issue. Probably one of the ways that we're going to do things differently is we're going to string wires or fiber optics across Alaska. We're going to have to use telehealth on wherever we can to keep the facility costs down. And then the cost transfer question has to come up in real earnest is if you save on the facility costs and you get better healthcare delivery, how do you share in the benefit of that? I think we need to have a good conversation. There are legal barriers probably, and there are probably payment type barriers. I'm willing to look at those. I think many legislators are. I think that's going to be one of the issues. That's not going to be the only one, but I think across Alaska, transportation, it really kicks the feet out from under us.
Where do you think the legislature or your caucus or any perspective you might offer, where does the legislature look for insight and answers to help solve these problems? To associations like ASHNA, particular providers within a district?
Certainly when ASHNA comes and talks with us, it has a significant impact. We put a healthcare commission together to think through those things. It's got it's got a good life. It's probably limited because you have people of certain interests, and it becomes kind of an interest. They don't encompass the whole industry. For example, you can't focus on every aspect of it. So I think what people bring your voices together, child wellness ends up in my child protection system in a huge way. And you have to keep making those connections. There are so many places where it comes to be on, we live in a good time in history. Once again, the safety culture in our industries is good, but we do risky behaviors in almost every other way. So we have to change that culture because we can't afford to pay for all the risky behavior we're doing.
Yeah. Do you think that recognizing Governor Parnell made a decision in 2013 and 14 to not expand Medicaid, do you think that that should be revisited in out years as an opportunity to? Do you think that Medicaid should be expanded in the out years, in future
That's
years?
what I was waiting for, that direct question. Should Medicaid be expanded?
I figure you have an answer for it.
My first answer is no. And the reason is, first of all, it's borrowed money. And it has to be proven to me that borrowed money helps us repay it back. Because so the value has to be greater than the borrow. And I don't see that yet. There might be ways we can get there. The only way that I would even consider it is if we as a state looked at, okay, if we had to pick up that population, what would we end up having to pay if it was full tilt on us? Because what we did in Medicare was in 30% increments, we began to drop Medicare, right? Or maybe it wasn't that dramatic, but it was pretty significant. The hospitals took the biggest beating, I think. That will come our way again. The other thing is, if saying that population is worth the effort, then I want flexibility in implementing it. And there are probably ways that we could make that flexibility work. That would be my only way that I would even consider it, is if we had some serious flexibility in our health payment plan, or our health plan that MMS gets to look at.
If you think
CMS, I'm sorry.
If you think, if Governor Parnell or Governor Walker came to the current legislature, if the current legislature were all reconstituted hypothetically next session, and supported Medicaid expansion, do you think it could even get through the legislature, assuming he
potentially possible? Yeah, potentially possible. But guys like me are going to say, we've already done under the Affordable Care Act, we've transferred the payment to the healthy population, and we didn't even cover the cost of doing that. And now we're going to expand to another population, and we're asking that healthier population to carry that too. And by the way, it's not this generation of healthy people that's going to do it, it's the next generation.
Julie, I know you're chomping.
I got a lot of thoughts on this one. So the other thing to think about is what's the cost of not doing it? And in my career as a nurse, I've seen 2 different patients with $750,000 and $1 million bills from an abscessed tooth that went septic, and they were in ICU for months. And it's that level of care that we're missing. So when I think about being a penny wise and a pound foolish, if we're not in front of the prevention side and taking care of those things up front, I can imagine what I could have done with that $1 million patient. And by not having the dollars to support the people, have the diabetes checked and get their blood sugars managed and get their hypertension under control, they're going to end up as a stroke. And so the cost for that just continues to escalate if you can't get in front of it. So I hear you. I'm not necessarily saying, yes, Medicaid expansion, yay, Obamacare, but I am saying there's got to be something to get in the front of these patients that are in our system now, and they're costing more and more money. So that would be the other consideration, can we afford it or can we afford not to? And that's the ones that I see in our hospital and in our emergency room on a regular basis.
Yeah. So, another key element, Robin, of the Affordable Care Act is the creation of exchanges, obviously. And for a number of reasons, elimination of high-risk pool, grandfather health plans, et cetera, the 2015 proposed rates have reported to have been 37% from Premera and 27% from MOTA. In the state with the most expensive health care in the country, that has the most expensive health care in the world, even though the small group market is relatively flat, where most of the lives are, or many lives are, 37%, 27% sure seems like a tough number to stomach. What do you think as, from the health plan perspective?
It is. I mean, candidly, it's a difficult number for everyone. I mean, none of the carriers like to put that number out.
Yeah.
There's a number of factors that obviously have created that. It is a small risk pool. A lot of the high-risk population were moved into the pool without any safety net or any kind of reinsurance protection. Yeah. The market is designed for, even with insurers, to pay money amongst itself for high risk or adverse risk selection. I think that the thing that we would say is there needs to be tweaks on the way that healthcare is financed. That the Affordable Care Act is a misnomer to some degree. It provides coverage for people, but it didn't address the cost issue. Mm-hmm. And that's the glaring factor that you see in these recent increases.
Yeah. So I want to also engage all of you in questions. And we've got a couple of folks who will have mics walking around, handheld mics. So if you have a question, raise your hand and we'll get you included. Becky, I want to ask you, 37% rate increase, some people might call that, in fact, some governors in other states have called that too high and didn't approve that. But 55 to 60% of the cost of a health premium is in the form of hospital inpatient care. Health plans would say, though this health plan didn't when given the opportunity, that's because of providers, and providers are very expensive here. It's not us. As health plans, it's providers. How would you respond?
Yeah, that's, healthcare costs are a combination of your provider costs, but also utilization. Yeah. And so it's an oversimplification to say it's just provider costs. What has happened, I believe, is we had a high-risk pool. We had very sick people whose only access to insurance was through the high-risk pool, who have gone into the exchange. It's a math equation, and it's a complex math equation. I'm not an actuary, thank goodness, but it's a complicated equation, but it does come down to how do you share risk when you have the congestive heart failure patient, when you have the very expensive cancer patient. And in order to share risk effectively, you need a large pool, and we don't have a large enough pool to share the kind of risk that we're seeing. So, that's a very simple, my simple explanation as to why we're seeing those premium increases. The question is, what are we going to do about it? And we've seen a lot of this going on about why rates were high. It was, blame. Won't go into that, but that's not going to get us to a solution. And what we really need is to sit down, to figure out, to talk to the federal, is more flexibility required for a market like ours? Do we need to do some things differently? What do we need from the state perspective? Mm-hmm. Those conversations are the crucial conversations that need to happen. I don't have an answer for the plan, but I think there are answers that are out there if the conversations will occur.
Robin, you wanted to comment?
I was going to, in one of my other roles, I am the chair of the high-risk pool, the Oregon Minimum Insurance Pool in the state of Oregon. So I've been dealing with this I'll take my MOTA hat off, but I've been dealing with this from a state perspective for the last several years. And we had, for example, 70 individuals who were on dialysis. They were spending almost $25 million a year. That was almost as large as our yearly assessment just for 70 people. So you put those people into the exchange, and that individual market, what do you think is going to happen? Yeah. I mean, it's just simple math. And there are potential solutions that can be explored, and I think that's the discussion that's going on right now, is how do you mitigate some of that impact?
Yeah. Do we have a question over here?
Yeah, thank you. Boy, I got a lot of questions, but you touched on a subject that was, what you just said. Your hospital has spent over $1 million for an abscessed tooth. I'm a dentist by trade, so everyone knows that. But that's really the problem right there. And what I want to talk about is medical tourism. And how are we going to address that issue? Because in the state of Alaska, everyone in this room knows it costs us more to do business in this state than any other state in the union. We cannot compete with the prices in the lower 48, and the lower 48 cannot compete with the prices outside of this country. So as insurance companies go, how do we deal with this problem? That's my question.
So as insurance companies go, Robin, representing all of the insurance companies in the marketplace,
Of course.
how do we deal with medical tourism? I think what Representative Higgins is saying is that we should not have medical tourism. Nod along or shake your head, Representative, if I'm incorrect, but how do you respond?
Well, what I would say is there are models that we've been working on, that the goal is to keep care in the geography, that when care leaks out, you hinder the infrastructure, you devastate the infrastructure that exists, and you either have to make a decision: are we going to keep and build on the infrastructure we have in our communities, or are we going to let it deteriorate? And I think there are models. Again, I'll go back to that concept where you can develop coordinated type care models where there are savings, you can have outcomes, you can get providers to the table. In the existing, and I'll go back to my other comment, if we look at the existing system today, it is not sustainable. That's why we have medical tourism. We've got to look at some new approaches, some new models that can keep the care in, share the savings with the providers, and I guarantee providers will come to the table. I've been having these conversations with providers in 3 different states for the last several years, and I guarantee providers will come to the table if you can put a model together that they can work with.
Noah, you had your hand up.
So I'm a family doc here in Anchorage, and I've come 4 years in a row, I think, and served in a number of other positions on the commission and on the prov board and as president of my practice and all that. But there are a couple things. One is a question: do we have enough money? No. And the reason is things like the new treatment for hepatitis C, which is online this year, is wonderful. 12 weeks, 85% efficacy, 3.5% of the boomers have it. It's great. It's like a miracle, but it's $150,000 for the pills. Now, that's a lot of money. You could provide a lot of primary care for that or any other thing. The other comment is evolution is used in the flyer. To a great degree, and a lot of other docs have put a lot of effort into this, and we think we could do a better job. But you don't get to evolve into what you want to be. You have to evolve into a niche. There has to be food there. And we got to be paid for what makes sense.
So, Noah, this question of maybe changing the model, right? Maybe there's enough money if we change the model, and you run one of the large 2 primary care practices in town. Would your clinic and your physicians be willing to enter into a shared upside kind of model? It's really putting you on the spot here, but I mean, if we're going to change the system, I think it probably starts with primary care empowerment, but primary care docs need to want to be empowered.
Yes.
You heard it here first. Some of you have already heard it, but
So
They will.
I just want to say the intrinsic motivators, which is really what runs all doctors, I think, and most people in healthcare, is to do the right thing, to have autonomy, and to take good care of our patients. Those are there. A lot of systems are built where that's actually very, very difficult. There are workarounds, and I'll pick on the VA. I don't think anybody's here. That got so severe that people are lying about their own metrics.
Yeah.
That's not healthy, right? So what we need is the intrinsic and extrinsic motivators to be in alignment so that my paycheck, extrinsic, and patient wellness, intrinsic, are in line together.
Yeah.
We would like to do that, and we do it already. It's just we don't get paid for it.
right. That's right. Over here, sir.
I had good fortune to listen to the legislators this morning, and Senator Kaga mentioned something just kind of in passing about transparency, and that intrigued me. I note that the state of Massachusetts just passed some statutes, I think just the other day, for pretty much full pricing transparency for all providers. And I'm just wondering, I know that, we've been talking about providers changing the way they do things, but I think part of the individual client's accountability is to empower them to make decisions, and part of that is to know, what the costs are themselves too. So I'm kind of interested in if you have any more thoughts about that, Senator.
Sure. There's probably a couple of ways to get there. You can do it with mandates, or you can do it with collaborative work, and it's a little more complex than I can describe here, but the answer is yes, transparency, the best we can get, so that the consumer knows the value and the cost, and the payer knows that that consumer is well informed. And we're just not there right now, and that's one of the fundamental changes we have to make. How will you get to that transparency? You can't go into a hospital and have 50 things on a door. So it has to be, we have to think that through. I am open to discussions. I'm going to look at some of the models that have been passed through other states. We are unique. That is true. But paying for value and the cost of that value are things that the consumer just needs to know, and we just don't know it.
I agree.
Sir, right here.
Yeah, I'm a family practice doc. I'm head of the third largest clinic in Anchorage. Talking about shared savings and so forth bothers me a little bit when the cost of medicine is so high and we're looking at ways to save patients' premiums and so forth. You know, we're saying, okay, if you save money, the doctor's going to get half of it, and the insurance company is going to get the other half of it, and how much is the patient premium going to get? I mean, I don't think that there's, I don't think that doing a kickback type system like that is really in the public's best interest. Unfortunately, the answer to the problem is so simple. Nobody really brings it up and addresses it, and it's basically to have people pay out of their wallet when they go into a clinic's office and they decide that, I want this care, I want that care, I don't want the MRI, I'll let it go another couple weeks or so forth, rather than third-party payers. Oh, well, I've paid my premiums for 4 years and I haven't used my health insurance, and I'm going to Hawaii, so let's get an MRI today and be done with it. And, like Julie, you said, what would you do for your mother? Your mother, you're going to sit down and say this and this and this, but a very valid part of the problem or the answer is going to be, okay, how much is this going to cost, Mom? And how much do you have in savings? And how much do you want to shell out for a trip to Rochester to go to the Mayo Clinic to get the expert or whatever? And Affordable Care Act has made this much more difficult to have a cash-only practice where you post the prices online and this is what it comes here, and people could choose, I don't need insurance at all, I'll just pay for my care out of pocket. And then, having some sort of a backup health savings account, kind of a major medical, is basically, in my opinion, the answer to the healthcare problem, because, insurance is not, these are not insurable events. I mean, paying for people for preventative care and paying for 3 visits a year, that's not insurance. I mean, you don't pay car insurance and have your oil changed and have that put on an insurance plan.
So, sir, let me ask you as a physician a similar question that was posed to the senator, but reflecting on what I saw Deb Erickson had of the Healthcare Commission in her slides on transparency today. One of the line items was that some states, in supporting transparency, require all physicians, regardless of provider venue, to post their prices, all of their prices. Do you think that that is an appropriate bit of legislation that the legislature should take up to support the thing that you're talking about?
Yeah, I mean, if everybody was doing that, I wouldn't have a problem posting my prices online. I think that would be good for everybody.
Yeah.
There are other caveats there. The price alone doesn't say it. You have, what's the accessibility? Are you being seen? Are you going to have follow-up? Is it a physician? Is it a physician assistant? And there's a lot of other things that need to be factored in there. Yeah. But that would go a big step towards helping with that problem. And it needs to be across the board. It needs to be the specialists. It needs to be primary care and so forth.
Right. Good. Sure, please.
Yeah, I just want to add to this discussion. I think, I'm a pretty small government person, so I generally favor collaboration and voluntary, voluntary decision making rather than legislation. And I think we're at a point where, from a quality standpoint, there is much more publicly available information than there ever has been. And do we need to, from a provider side, do a better job of making it easy for consumers to navigate our pricing systems? Absolutely. But I do want to make the point that the conversation about transparency without a conversation about benefit design is not useful. Because if your plans are still structured so that most of everything is covered, the consumer has no incentive to care about transparency. So I will say here, when I was with the state, I was moving toward a consumer-directed health plan for state employees. I don't know if that work is continuing, but I'd suggest that if you're not willing to, at least even in your own state employee plan, look at a consumer-driven model, why then are you going to take on transparency from a pricing standpoint? Because it will not make a difference at all if you do not have consumers incentivized to find out the price of things.
That's a great point. If consumers don't have a little skin in the game, then the pricing really doesn't matter, right?
No.
So, in the absence of a hand up, let me ask you this question, Becky.
If I could
please
chime in on that,
Yeah.
because that's the thing that the legislature has to look at. First of all, we have a body of people that we're trying to direct the care for. So we're going to go to the hospital and we're going to bargain with them, right? And so there's a healthcare package. I'm not going to go to a doc and do the same thing. So that's the other thing. Hospitals might get a special kick-in from the federal government called disproportionate share, although it's less and less of a share. I understand that. But a doc doesn't get that. And so those are, and then you might have MRI where you get good value for it, and then at the ER you have to pay that value out. So you have these cost shifting things. I don't know if docs have that same thing. So those are the kind of things that transparency brings real problems to. You can't just put a price on the front door. And that's why I say it's complex. But at the same time, if a consumer goes there and they know, hey, I could get a better value somewhere else, no matter, I don't mind your cost shifting, just give me an idea that this is going to cost me $10,000 or $2,000, and if it's $10,000, I might take a plane ride and do that tourism, because I can tell you, follow the dollars. I mean, and if it's transparent, then we will begin to be creative. And I can tell you, for the public pay, which is the safety net issue, we are going to do consumer directed as best we can, but we're going to direct the consumer, right? Because we're the payer, and it's a safety net. But when a company does it, they're paying an insurance company to look out for their best interest. And that's the problem with the transparency. It is, everybody's involved in it, unless you start peeling that back a little bit and say, okay, maybe there are basic things that we can put that we know we can deal with. Immunization, osteo issues. Maybe there are pregnancy issues that we can deal with that we kind of know the realm of cost in them. Maybe those, what we need to do is have categories where you have good price sensitivity built into categories, because on each procedure, it could be very different. I might be a diabetic, it's totally different than somebody who's a non-diabetic. Very different treatment. So you can't just put a menu up there, but categories, I think you could.
I'd like to add to that too, because one thing we have at Alaska Regional is actually financial counselors that you can call and say, what's my price going to be, and here's my plan. And actually you can go one step further and say, do you offer a prompt pay discount? Do you have an opportunity for me to pay it differently so I can have a reduced rate? I mean, those things exist, and people don't even realize that that's a possibility, that you can negotiate those things. So it's a balancing act to making sure people understand, but at the same time, if all the shifting is happening from medical tourism to the lower 48, and the core reason you need a hospital is for emergency care and taking care of the very sick and ill, you're going to have cost shifting again. It's only going to get more expensive because the cost of doing business is really built in. And I'm not trying to be defending the hospital environment, because I'm a utilizer of it as well, but being able to balance what you need inherently just to be ready for whatever comes in the door with the elective business, and making sure that we're not having that medical tourism taking place is definitely an art form. And I believe there's opportunities there to adjust that.
And as a matter of policy, as a country, decided when somebody shows up at the ER, you can't turn them away. Hence, we were going to kick up for those who are the disproportionate part of pay. One's going away and the other's not.
Yeah. Yeah. So I want to wrap up with a question I'll pose to each of you in similar but perhaps slightly different ways. With the preface of, Senator, in your session, I heard Representative Seaton say that the legislature had passed unanimously, both houses, in 2011, a directive or a vision statement to the administration to move to a healthcare system that based more largely on value rather than fee-for-service. And his statement was, we really need the private sector to really lead that and sort of guide the administration and state government towards what that future looks like. So here they are. What would your advice to the healthcare sector be as a senior legislator? In sort of about 60 seconds, what should this group be doing as they think about transforming healthcare?
Once again, I don't know that I'm really qualified. I appreciate so much what you guys do, you men and women do day in and day out. So God bless you, thank you. I think it comes down to pay for value again. It's not the fee for service, it's the pay for value. And we've got to align those things up. And that is even prevention. If we're going to ask people to be responsible for their own health care in prevention, when they don't do it, it's got to cost them. Yeah. But the trouble is, what do you do with diseases that are passed on from one generation to another? So we have to have some safety net capacity, but we also have to have responsibility involved in it. And I am open to discussion on how to get there. To the healthcare community, I would say on the face-to-face, day-to-day meetings, who is the misuser and who is the reluctant user. And you have to encourage the reluctant user, and you also have to instruct the overuser.
Great. Yeah, Julie, your advice to the healthcare community on how to move us forward?
Be your own advocate, for one thing. I think to be your own personal case manager in how you manage your personal health and wellness and that of your families. Make sure you're informed and latch on to a great primary care physician, because I quite frankly think that we are missing a step by not including the primary care right at the front door. Part of our healthcare issues and costs are related to going straight to a specialist instead of going to a primary care physician first, who might give you an option that might be, a less expensive alternative. So, and having seen that lower 48, it's a model that at least gets you in front of making a decision instead of going right to the end at first.
Great. Robin, your thoughts as folks here are about to break for the other breakout sessions. What advice would you give the Alaskan healthcare community?
Be part of a broader conversation. Engage with the legislators, engage with employers, engage with each other. Be part of a broader conversation. This isn't just about you, it just isn't about what you're paid. It's about total transformation. It's about transformation in the care that you provide, the way that you provide care. It's transformation in the way that you're paid. It has to be tied to consumers from their pocketbook as well as from their outcomes. Everybody has to be part of this, and what's happened is we talk much amongst ourselves or with each other, or we talk with certain sectors, but we need to be part of a broader conversation.
Becky, last word. What should we be thinking about?
So I think we need to think about what's the delivery system going to look like in 10 years. We know it's going to look different. We don't know. We're all struggling with what that means and what it looks like. But I think the question for us is, who's going to lead that conversation? Is this going to be led by the state? Is this going to be led by payers? Is this going to be led by healthcare providers? Ultimately, it's probably a conversation among all those groups. But who's going to lead? Because I think we need to think about who's going to step out and lead to help create what that delivery system looks like.
Let's give these guys a round of applause.